Hi, welcome to Fertility Talks. I'm your host, Mary Wong, and I want to thank you for being here. It's my live post number 106, and I'm so pleased to be having Dr. Ari Baratz with us today, and we're going to talk about fresh versus frozen. I hear some, how's the sound there, Dr. Baratz?
The sound is excellent. Thank you, Mary.
Okay, cool. All right, I was hearing something in the background, but okay, great. So a little bit about you before we start into the heavy meat of the conversation. Dr. Ari Baratz, who I know as a reproductive endocrinologist at Create in Toronto, has been in the field for over 15 years. And how I met him was through Create. And I don't want to go into more details beyond that, but I was so impressed that you came to my book launch from my book Pathways to Pregnancy, and being so open-minded and welcoming and open arms in terms of integrative medicine. So thank you for that.
My pleasure.
Okay, so right from the get-go, I said, hey, why don't you just figure out what you want to talk about? And you laid this on me, which I loved, about fresh versus frozen. So why don't you I'm just going to hand it over to you and tell me a little bit about the difference between fresh and frozen in terms of, first of all, sperm, then eggs, then embryos. So go for it. About sperm first.
So do we have 3 hours for this podcast, or is this...
First of all, we're going to 20 minutes.
Thank you again for inviting me. And I think it's a really important topic, Mary, because there's a phrase that we all know, or we believe, which is fresh is best. We talk about that when we talk about food or maybe other areas of our life. But when it comes to reproductive technology, most areas have now shown that fresh is not necessarily best. And we'll discuss that in terms of eggs, sperm, and embryos. So I'm happy to start with actually sperm, because that's probably the oldest cell type that's been frozen successfully. So first of all, there are many examples of on a routine basis where we use frozen sperm. Many of our patients using donor sperm, either through a known donation or an anonymous donation, are using frozen sperm. There are many advantages to using frozen sperm. It allows you to time other techniques in a more user-friendly fashion. It does allow, we have the cancer population that are going through therapy. By freezing their sperm, it allows us to save that sperm before they go through some type of toxic treatment to the testicle. And in many cases, sometimes we have just social issues, availability of a male partner. By freezing sperm, it allows us to have access. So there are many, many applications from freezing, but the deeper question is, does that compromise quality? And for the most part, with a normal semen analysis, we see that there are very high recovery rates of sperm that you freeze and thaw for application with no meaningful change in outcome. So the bottom line is frozen sperm from a normal male will work just as well as fresh.
And then so quickly, and just to add in, would it matter in terms of age for male sperm?
Well, now that's another podcast, age of the sperm. But
yeah, I know. Another 2 hours.
Well, there's 2 questions. So first of all, and this is a common theme that's asked about freezing, and this would apply for sperm, egg, and embryo, which is how long can something be frozen for? And there really is no expiration date, assuming all of the conditions of the freezing apparatus are maintained. So it doesn't matter if sperm is frozen for a decade or 2 decades or 3 decades. Similar for eggs and embryos, they really don't decay in the freezing chamber. But you were asking, I think, the age of the male providing the sperm. Is that one of your questions?
Yes, absolutely.
Okay. In general, most data up until very recently suggested that male age is not impacted as long as other factors are controlled for in terms of outcome. Recently, there was some data that said that maybe there are some conditions that are impacted by the paternal age or the age of the sperm provider. Conditions like autism, maybe some heart disease or cancer may be impacted by age of male provider. But I wouldn't say that that data is strong enough or robust enough to deter more senior males from fathering children. It's an area that's still being investigated.
Okay, so then let's move on to embryos before eggs, actually.
Sure. You're in charge, so I'll let you. So, it's interesting that you want to move to embryos, because embryos would probably be the next entity that was frozen successfully. And a lot of this freezing technology evolved in the 90s, so a little bit before my career started. I know I've been doing this for a while, but I still am looking back on some of the advances. And, IVF began in the late 70s and then matured in the 80s, but the freezing, the cryobiology really took off in the late 80s, early 90s, because up until that point, if you didn't have a fresh embryo transfer, you really were compromising your outcome by many-fold. Many would say there was a 2 or 3-fold gap between the fresh IVF success rate, which was already quite compromised in the 80s and early 90s, versus the frozen. So pretty much freezing embryos was really a futile, maybe not futile, but really was inferior. And then there was a major change in the field, a term that I'd like your followers to learn, which is the term vitrification. I wish we had like a little caption, vitrification. And what vitrification did, it's a technique of freezing that replaced the traditional slow freeze technique, and you may have heard about it. And what vitrification involves, it comes from the Latin glass state, and it ends up freezing embryos without creating crystal. And crystal is very toxic to cells like embryos. It shears the cells, it compromises the quality, and it prevents high survival rates from thawing. But when you vitrify an embryo or an egg or sperm, you improve its survivability, if that's a word. I just made that word up, but its ability to be used. Its
survival rate, but that's okay.
Survival. And so, so what vitrification did was it took that gap between fresh and frozen embryo transfer, and it just eliminated it to a point where we currently have, I would say, almost equivalent success rates between fresh and frozen within a standard deviation mark. And in fact, at the last Canadian Fertility and Andrology Society meeting of this past year, this was the first time in Canadian IVF history where there was a higher number of frozen embryo transfers than fresh, elective. So, I mean, that just shows you how the field is shifting significantly, and without any compromise in outcome. So,
yeah, and let me just add in then, there's some clinics I know that are actually opting to do freeze all rather than any fresh transfers.
Yeah, so that's a so there's a bit of a delay in the mic there.
Yes, there is.
So just to repeat your question, you're saying that some clinics are opting for a freeze all policy so that they're essentially eliminating the option of fresh transfer. It's an interesting point. Fresh transfer does pose some challenges. There's another issue we deal with very often in IVF, which is the consequence of high dose stimulation or ovarian hyperstimulation syndrome, or OHSS. And one of the strategies to eliminate that condition is the freeze-all policy, or a more liberal freeze policy. I think a lot of that comment has to come back to the clinic that your follower is using, because some clinics have higher success rates with freezing. I would say most clinics have adopted the vitrification technique almost on a universal basis. It is more labor intensive, but it's become the standard. Right. And so I think freeze-all might be a bit extreme, because there are some patients that still believe in that initial adage of fresh is best, or they may have some type of sentimental connection to a fresh embryo transfer. So we don't eliminate that option in our practice, but we certainly use sorry, you're thumbing me up. Oh,
I did, because I believe that, every case is unique and individualized. So, right. I mean, I have seen it where, oh my gosh, this person does better with the fresh versus frozen. So,
Yeah, and as well, I mean, so that's where you get into that sort of sentimental, and some people are very superstitious about what has worked for them. And maybe there is a biology behind that as well. I mean, there probably are certain systems that are more apt for fresh versus frozen. I mean, the data doesn't necessarily support that on large scale, but when you really mine it down to the individual, if you subscribe to patient-centered fertility care, then you'd like to have a situation where you could offer fresh or frozen. There are some other, I call them sort of more program-based reasons for doing fresh versus frozen. Certainly, from a scheduling perspective, freezing is a lot easier because then you can plan a frozen transfer, and your provider can review that in more detail. And certainly, women, when they are going through, both men and women, but women in particular who are going through egg retrieval, it's a pretty intense process. And to have more than just 5 days or 6 days break between your retrieval and your transfer, for some women, allows them to recover. And maybe even if the data isn't fully in support of it, they themselves have that recovery time.
Do you want to add something with regards to day 3 versus day 5 embryos?
Mary, you're squeezing me here for.
I'm sorry.
I think day 3 versus day 5 is certainly an excellent topic, and it does extend out of the whole discussion about fresh and frozen, because the extended culture to day 5 allows us to do advanced testing on embryos. It allows us to increase the metrics that we can acquire about development. That does speak also to the individualized care. I mean, certainly if there's many embryos that are developing, or if couples are suffering from other conditions that warrant pre-implantation testing of embryos, there's really no question you're talking about a day 5 transfer. And that does require a very strong cryopreservation freezing program, because many of those embryos will have to be frozen. But day 3 embryo transfer is not a complete extinct technology. Certainly there are many parts of the world where day 3 transfer is actually the standard, and day 3 cryopreservation, which is probably not the best time to freeze embryos, but certainly is an option. So, again, in a patient-centered open practice, individuals should have that option if it's reasonable. Certainly, if there's no reason for selecting embryos, if there's a smaller number of embryos, day 3 transfer is certainly acceptable. There is some data that supports day 3 transfer for certain diagnoses, like male factor infertility may benefit from an earlier transfer. So there's still room for day 3 embryo transfer. But again, my comments are really very general. I think you'd have to look at the case specifically with your own provider to know which is best for you. So those are the sort of comments on embryo. I think you were asking about egg. That was your last question, right?
Yeah. Well, just because of the fact that, it's now become more of a thing with egg preservation, whereas before it wasn't so much. So I just want to keep that asked.
So there's no question that egg cryopreservation is one of the newer technologies of all these new technologies. It's the new kid on the block in terms of being offered. One of the biggest challenges in cryopreservation in terms of sperm or embryo or egg was the egg. The egg is a very large cell. It's full of water relative to its surface area. And so vitrification, this newer technique, really revolutionized egg cryopreservation or egg freezing. Initially, egg freezing was really reserved for the oncology population. So female patients who were going through either chemo, radiation, or surgery that would immediately compromise their future fertility. And then over time, the elective egg freezing population, so what I like to refer to as the non-oncologic population. Many people use other terms like social egg freezing. I'm not a big fan of that term, because I don't think of it as a social experience. I think of it as really a major decision with medical, emotional, and financial impact. But that's another term that's commonly used. Whatever the term you're using, whether you're freezing for oncologic reasons or for elective reasons, it certainly is a viable option. Certainly something that has changed the way a lot of women live their lives and decisions that they make. And it sort of has come in as a temporizing measure against other social factors like extended contraception. There are many women, just like men, developing extensive careers, delayed childbearing, and egg freezing has allowed them to put a almost pause on the biological clock with a reasonable outcome.
Yes, and I like the way you added reasonable outcome, because it's not a perfect outcome. And for those that are watching with regards to this topic specifically, I want you to err on the side of caution, because it's not 100%. So don't think that, you could just bank some embryos and it's a done deal, because there's still a risk that it may not be or may not fertilize appropriately. There's just so many factors that it doesn't necessarily result in a live birth. And if it still stands true, I think my calculation was, it's like 1 out of 21 eggs actually make it to a live birth. So it does require a large number of eggs being retrieved from IVF process, right?
Well, that might be a bit extreme. I think 1 out of 21 would depend on the age group that you were looking at in terms of achieving live birth. But there definitely is a gap between the number of eggs that are frozen and the number of embryos that are generated versus the live birth. Definitely. You mentioned, I think you were trying to say egg, but you said the word embryo. But that's a good point, which is the person that's undergoing fertility preservation, whether it's for oncologic or non-oncologic, should always be offered the option of either exclusive gamete, like just egg freezing, or freezing as an embryo. We typically counsel patients. I know I counsel patients on both options, and in fact, in an ideal world, the patient would have a combination of both eggs and embryos, for the simple point that people often perceive egg freezing as a biological insurance policy that has 100% return. And it's not like your auto insurance or home insurance where you can actually provide a concrete deliverable, pun intended. I mean, you just can't guarantee a deliverable baby from the number of eggs that you freeze. But what you can do is you can help people plan, and you can try and create a target number of eggs to the age that you're freezing at to give someone a reasonable outcome. So for example, we would say that to achieve, let's say, a 70% pregnancy rate, let's create a very high number, right? That is a reasonable number. So that target number of eggs frozen for a woman under 35 versus 38 versus 40 will be different, right? So a woman under 35 would try and target, I think you were a bit generous with your egg number, but I would say about 12 to 15 eggs would be enough to give someone a reasonable return on that egg investment. 35 to 40, you're probably looking at now into the 20s. I think that's the egg number that you'd be looking at. The problem is the individual over 40, now you're starting to get into very large numbers, maybe 25, 30, 35 eggs to achieve a reasonable pregnancy rate. And the problem is that we're limited by how many eggs we can harvest with each retrieval. That's the double-edged sword of egg freezing in a over 40 population, which is egg reserve typically declines at that point. So now you're trying to harvest a higher number of eggs in a lower quality pool. So we don't fully discourage women that are over 38, over 40 from egg freezing. We certainly do discuss it with them. We try to be as transparent as possible in terms of reasonable outcome and reasonable expectation, and considering adding in frozen sperm to the equation.
Right. Well, thank you. I think we've covered a lot in a very short period of time. So for the viewers out there, you can contact me directly, and we can always get this conversation going on further. But I think as of now, we'll relinquish you because I know that you're on call. So I really want to thank you and appreciate your time and effort to be here. And we were supposed to do it a little earlier, but you made it anyway. So I really appreciate it. I love this. And for those viewers out there, thank you for joining in. And we will actually going to have another Fertility Talks this Wednesday, which is going to be on endometrial receptivity. So, and that'll be with another guest from the United States. So that'll be 8:30 Wednesday, Eastern Standard Time. And also, I want to announce that on Sunday, I'm going to be doing my last fertility circle, which is basically about mindset and how we can thrive in the process of while we're going through fertility challenges. So please join me there. And again, pick up my book, Pathways to Pregnancy, if you haven't done so already, for some hope and practical advice. Thank you again, Dr. Baratz, for being here, and you have a very good night, and I'll see you all next time. Okay, take care. Bye for now.
Bye. Thanks.